Good evening, one and all. I am Dr. Dhinesh Balaji, Pediatric Surgeon. Today, we're going to discuss the 2023 Pediatric Surgery questions. The first of those are the first question is: 3-month-old child is brought with a sternocleidomastoid tumor. What is the next step in managing the child? See, the options here are observation, surgery, physiotherapy, and warm compress. So the key here is the child is 3 months old. So the possible options here are it's either observation or physiotherapy. Okay. So the answer here is physiotherapy. So sternocleidomastoid tumors resolve spontaneously in most children. The rate of resolution is better if the next stretching exercises are incorporated very early. That is, we make the child to look in the same side as the sternocleidomastoid tumor. So when the tumor constricts the sternocleidomastoid on the same side, the child is not able to tilt the head on the ipsilateral side. The same side as the tumor, the child will not be able to turn the head. So we'll keep something that the child likes on the same side as the tumor. We'll do gentle stretching and stretching exercises so that the muscle relaxes over time. So usually this helps most children. What are the indications for surgery if required? The indications are persistent sternocleidomastoid tumor in a child more than 1 year of age, or persistent sternocleidomastoid tumor in a child with progressive hemifacial hypoplasia, or persistent sternocleidomastoid tightness with limited head rotation in child more than 15 months of age. So the common complications with sternocleidomastoid tumor are hemifacial hypoplasia and plagiocephaly. So in case of these complications, we advise earlier surgery. If not, we usually do gentle stretching exercise only. Okay. So this is a child with a right sternocleidomastoid tumor. As you can see, the head is slightly tilted towards the left. Okay. So question number 2. A 4-year-old child is brought with an inguinoscrotal swelling, which increases as the day progresses. It is non-reducible, has no cough impulse. What is the most probable diagnosis? This is quite easy. So the options here are congenital inguinal hernia, congenital communicating hydrocele, undescended testis, or encysted hydrocele of the cord. So the key here in the question to note is it is an inguinoscrotal swelling. It progresses as the day progresses. Okay, and it is non-reducible. It has no cough impulse. So it cannot be a congenital inguinal hernia. The only possible diagnosis here is a congenital communicating hydrocele. Okay, the answer here is option B, communicating hydrocele. So what are the possible things that you can get with a patent PV sac with hernia and hydrocele? It can either be a communicating hydrocele, or it can be a non-communicating hydrocele, or an encysted hydrocele of the cord. As you can see, in the communicating hydrocele, the PV sac is quite thin and narrow. So it allows only the fluid to come, from the peritoneum to into the prostogenitalis sac. Whereas in encysted hydrocele, it is not reducible, and the size doesn't vary as the day progresses. Okay, so the answer here is congenital communicating hydrocele. So question number 3 is a 1-day-old neonate has persistent bilious vomit, intolerance to feeds, and X-ray of the abdomen reveals this picture. What is the most probable diagnosis? So this is one of the most commonly asked questions in NEET. So as you can see, if you look at this X-ray, you will be able to see 2 bubbles. It's not a single bubble, it's a double bubble. So double bubble is commonly seen in diurnal atresia. The options here are pyloric atresia, diurnal atresia, gastric ulcus, and jejunal atresia. So in diurnal atresia, it is a double bubble sign. That is, the stomach and the duodenum are highlighted separately, whereas the rest of the bubble is completely devoid of air. So it won't show up in an X-ray. Okay. So these are the single, double, and triple bubble signs juxtaposed against each other so that you can compare against each other. So on the left here, we can see a single bubble sign where we are able to see only the outline of the stomach. It is seen in pyloric atresia and other causes of obstruction at the level of pylorus. Most common is pyloric atresia. The second picture here, we are able to see a diurnal atresia. The duodenum, the gas is seen up to the duodenum, probably second part of duodenum, beyond which there is no gas. In the third picture, we are able to see a triple bubble sign, most probably seen in ileal and jejunal atresias, probably high jejunal atresia, small bowel atresia. Okay, so here we are able to see the stomach, duodenum, and the distal bowel. Okay, so how do you explain it? What are the types of diurnal atresia? How do you classify it? So it's classified based on the anatomy of the atresia. whether the muscular cuff is intact or not, and whether it is separated by a defect or not. So the type 1 is seen here. This is the Gray and Scanlakis classification. So the type 1, in type 1, there is the muscular cuff is intact, whereas the mucosa and submucosa forms a septum-like structure. So the muscle technically is continuous, but the mucosa and submucosa ends in a septum-like structure. So this is type 1, it's seen above. In type 2, the atretic ends are connected by a fibrous cord-like structure. So there is no muscle in between. That is type 2. Type 3 is nothing but there is a gross defect, mesenteric defect, and there's a gross defect between the atretic ends. There is no fibrous cord in between. That is type 3. Okay, what is the cause of dural atresia? Dural atresia is caused by recanalization. Dural atresia is caused by recanalization defect in utero, whereas your regional and small bowel atresia are caused by vascular accident, vascular insult. Okay, insult early on. That is the core difference between dural atresia and the small bowel, jejunal atresia. Is it possible for them to present late? Yes, it is absolutely possible. We have seen children even up to 1.5 years of age. It is possible in a type 1 atresia where there is a hole, a dural membrane. We call that a dural membrane with hole. It is possible for them to present late. Can they have bilious or non-bilious vomit? Both are possible. They also can have, they can present with bilious or non-bilious vomit also early on. So what are the possible differential diagnoses? The possible differential diagnoses are an annular pancreas and a dural membrane with hole and dural atresia. These are the possible complications, differential diagnosis. So question number 4, which of the following statements about Hirschsprung's disease is true? So the options here are: ganglionic segment is dilated, aganglionic segments are collapsed. Option B, both segments are dilated. Option C, both segments are constricted. Option D, constricted ganglionic segment and dilated aganglionic segment, which is the possible correct option. The answer here is option A, ganglionic segment is dilated, aganglionic segment is constricted. Okay, so this is how a normal colon looks and juxtaposed with a colon with Hirschsprung's disease. As you can see, the ganglion cells migrate from, the neural crest cells migrate from the proximal to the distal, so oral to aboral. So it starts from the esophagus at around 4th or 5th week of gestation, ends up at the internal sphincter at around 10th or 11th week of gestation. So any issue in this migration causes a deficiency of ganglion cells distally. So distal segment is always aganglionic in Hirschsprung's disease. And what is the role of this ganglion cell? It helps the bowel to relax. Okay, it helps normal transmission of nitric and cholinergic innervation, and it helps the bowel to relax. Okay, so in the absence of ganglion cells, the bowel is constricted. Aganglionic segment will always be constricted, whereas the ganglionic segment that is immediately proximal to the aganglionic segment will be dilated. Okay. So question number 5. A 4-year-old child with an umbilical swelling reduces with a gurgling sound. What is the next step in managing this child? Options are observation, option B, surgery, option C, CT scan to confirm the diagnosis, option D, conservative management in the form of starving. So the key here is it is a 4-year-old child and it is an umbilical swelling and it reduces. So it is a reducible swelling with a gurgling sound. So the most probable diagnosis here is an umbilical hernia. So umbilical hernia, usually we operate when the child crosses 2 years of age. So if it is a true umbilical defect, we wait till 2 years of age. If it is not, if it is a paraumbilical hernia, whereas if it is a paraumbilical hernia, we advise early surgery at the time of diagnosis. But if it is a true umbilical defect, exactly in the middle, we advise the parents to wait till the child turns 2 years of age, as there is a high chance of spontaneous resolution by 2 years of age. If it crosses the 2nd year of life, we advise surgery at the time of diagnosis. Okay, and what are the indications for early surgery in a true umbilical defect? So, if the hernia is irreducible, if the hernia is proboscis with excessive ulceration at the tip, we advise early surgery. Okay, and the core difference between umbilical and paraumbilical hernia is true umbilical hernia reduces by resolves by 2 years of age, whereas the paraumbilical hernia does not, and it requires early surgery. Okay, question number 6. A 12-day-old neonate presents in shock with sudden onset biliary emesis and bleeding per rectum. X-ray reveals the following picture. What is the line of management for this child? Options are option A, observation, option B, emergency surgery, option C, CECT abdomen, option D, contrast study. So if you look at the picture here, if you look at the X-ray, we are able to see the outline of the stomach alone, only the stomach, and there is very sparse gas distal to it. So we can call that, there is some amount of volvulus going on. So the diagnosis here is a malrotation with volvulus. As the child is in shock, it has biliary emesis and bleeding perirectum, which is classically seen in malrotation with volvulus, not just malrotation. Okay. So diagnosis here is malrotation. And as the child presents with shock, it is not advisable to proceed for a contrast study or an contrast CT. It is advisable to go in for an emergency laparotomy as the bowel vascularity is at stake here. Okay, so the child will usually present like this. The child will have a scaphoid abdomen, bleeding perirectum, and bilious vomit. That is a classical presentation of malrotation with volvulus. And the X-ray will show a typically gasless abdomen or a stomach shadow alone. Okay, that is a classical presentation of malrotation. And the if the child presents with a volvulus with bleeding perirectum and hypotension shock, it is advisable to go ahead with surgery as early as possible. Okay. So what if we do a contrast study in the child with the malrotation? We'll be able to see something like this. So we'll be able to see the stomach, and here, if you see the picture, there is A and B. A is the normal configuration of the DJ flexure with pylorus. As you can see, it is at the same level. It is exactly behind the pylorus. That is a normal configuration. If it is anywhere away from that region, we call that a malrotation or a malrotated bowel. And if the bowel undergoes volvulus, then the child presents with shock. That is when we evaluate. Okay. Here in this contrast study, upper J, we have done an upper J contrast study. Here we are able to see a malrotated bowel with a typical corkscrew appearance. That is the duodenum there is some amount of volvulus going on. Hence, this is called a corkscrew appearance or corkscrew sign. Okay, typically seen in volvulus. Thank you.
Hello friends. So this is Dr. Vikashini here. So I am your General Surgery NEET SS faculty of DocTutorials. So in this module, we are going to discuss the trauma questions that appeared in the NEET SS 23. So let's get into the questions. So first one is all are components of damage control resuscitation except. So all of the components of DCR except whether it's to correct acidosis or avoid hypothermia or anticipate acute coagulopathy and treat it, and to maintain a mean arterial pressure of more than 90 mm Hg. So basically, the goals of the damage control resuscitation is to control bleeding, prevent sepsis, and to restore physiology by admitting the patient in ICU so that the patient is kept under monitoring. So the main goal of damage control resuscitation is to prevent the lethal triad of any shock, that is the acidosis, coagulopathy, and hypothermia. So it's a very direct question. So this is the lethal triad. So any damage control resuscitation or surgery, it aims at avoiding the lethal triad of acidosis, coagulopathy, and hypothermia. So superficially seeing, this question is a very direct question. So the rest of the options are you have three options. There is acidosis, hypothermia, and coagulopathy here. So the odd one out is to maintain MAP, which is not a component of damage control resuscitation. But still, to prepare for a NEET SS, the super specialty examination, the intricate details also must be known. The substance says that if at all you have to maintain a mean arterial pressure, then you need to maintain the mean arterial pressure within 85 to 90 mm Hg for 7 days following injury. In case of isolated head injury, then in that cases, maybe there is something called as autoregulatory mechanism that happens, so that at that conditions, the MAP will automatically rises beyond the 90 mmHg. So that was what is given in the option, right? So that's for an isolated head injury patient. It automatically, the MAP rises beyond 90. Otherwise, for a normal, like not normal, apart from any head injury, the MAP should be maintained within 85 to 90. Because even if the slightest, even for a shorter duration, slightest of hypotension will not be will lead to detrimental effects in a patient. So this is a very direct question. So what are the components of DCR? Acidosis, you have to correct acidosis. You need to avoid hypothermia and anticipate coagulopathy and treat it. And maintaining MAP beyond more than 90 is not a component. So moving on to the next, again a direct question. So splenic injury with active bleeding into the peritoneum is which grade? Grade 2, 3, 4, or 5. So active bleeding into the peritoneum. Now let's see the organ injury scale for this splenic injury scale, where grade 1 is if there is a subcapsular hematoma less than 10% or 10 to 50% or more than 50%, it's grade 1, 2, and 3 respectively. Similarly, if there is a parenchymal laceration of less than 1 centimeter or 1 to 3 or more than 3 centimeter depth, it's again grade 1, 2, and 3 respectively. And apart from all this, grade 2 and 3, there is something called as intraparenchymal hematoma, which is less than 5 centimeter, it's grade 2. And if it is 5 or more than 5, it's grade 3. Whereas coming to this grade 4 and 5, which is more or less similar, like both of this will be having a hilar injury or vascular injury. But the percentage of the injury only makes a change. And also whether the capsule, splenic capsule is patent or it's been ruptured, so that the bleeding extravasates into the peritoneum or not is what makes the difference here. So in grade 4, there will be a vascular injury or active bleeding, but still it will be confined within the splenic capsule. And though there is a vascular injury, if at all it's causing more than 25% of devascularization, then it's called as it's a grade 4. Otherwise, like any vascular injury with the bleed exceeding or extending beyond the spleen and extravasating into the peritoneum and with a shattered spleen, then that is grade 5. So it's a very direct question. But here, what is the glitch is that you need to understand the difference between the vascular injury and the active bleeding. So this is a CT showing vascular bleeding. That is a CECT abdomen was taken here. So in both this condition, there will be vascular injury. But whether it's a recent vascular injury or ongoing bleed is going on or not, how to differentiate is that. In case of vascular injury, there will be pseudoaneurysm or AV fistula. So pseudoaneurysm or arteriovenous fistula will be present. And see here, as this arrow mark shows here, there will be attenuation or contrast leak present inside or within the splenic parenchyma. And in the delayed phase, there will be decrease in that attenuation in case of vascular injury. But in case of active bleeding, still there will be this vascular injury, but this focal collection, even in the delayed phase, the attenuation increases. So that is what makes the difference between the vascular and the active bleeding. So I hope you understood. So if there is a focal collection, if it is still increasing in size when it is looked upon in the delayed phase, then it means that there is an ongoing bleed happening. And also you can see here, this is the contrast leak over here and surrounded by a hypodense lesion, which means it's a clot. So that the size is not increased. So probably this is a grade 4 splenic injury. CT showing a grade 4 splenic injury. So that is the difference between the vascular injury and the active bleeding. So considering, again, coming back to the question, so splenic injury with active bleed into the peritoneum. So the bleed is extravasated into the peritoneum, which means the splenic capsule have been ruptured. So the answer will be it's grade 5. Very simple question. So next is in a patient with non-healing fracture femur, what is the next investigation? Whether you'll go for X-ray or a CT or MRI or bone scan. Now considering this question, so the question is about the extremity trauma, that is fracture, but there is no potential. The fracture is not showing any potential towards healing. So in that condition, what investigation will you ask for? You'll ask for X-ray, CT, MRI, or bone. That is the question. So before delving into that question, let's get some insight regarding the fracture healing. So fracture healing, there are two types of healing. There is either a direct or primary healing or an indirect or secondary healing. So in a direct healing happens without a callus formation. That is when the gap between the fracture segments are very small, or there is a little or no gap at all between the two fractured segments, then this type of direct healing happens. So here in this direct healing, what happens is that because the gap between the two fracture segment is very small, so there is not it is not required for the like the other hematoma or something like that inflammation. Everything will be kept minimal. So all those inflammatory process will be playing very low over here. So this is more or less very much similar to a normal skeletal homeostasis where osteoclast mediated remodeling will be happening. So following that, the osteoblasts will start laying the lamellar bone. So it's very much similar to a normal skeletal homeostasis. Whereas indirect healing is not like that because the gap between the fracture segments will be slightly more distant in this like this example for this direct healing is a fracture line, a hairline fracture where inflammatory process will be very minimal. Whereas if the fracture segments get parted or there is a loss of segment of a bone, then what happens is that a hematoma starts first comes and fills the gap. And after that, there will be an inflammatory process which recruits all those inflammatory cells, fibroblasts, or everything will be recruited to that fracture site. And depending upon varying degrees of strain and also the influence of bone stimulating factor, the fibroblasts will now convert into the fibrous tissue. And then later on, a soft callus will be formed. And upon mineralization, there is calcium and phosphorus deposition, mature bone will be formed. So again, like there is a theory called as Perren's theory, in which it states that the amount of strain to the fracture site determines the nature of tissue it differentiates into. So whether the normal bone is formed or not, or what kind of tissue forms in the fracture site, whether it stays as a fibrous tissue or it progresses towards a soft callus or a hard callus or a mature bone. It depends on the amount of strain that is being, or amount of strain or amount of stimulus that is being given to the fracture site. So if there is 100% strain to the fracture site, then a mature bone will never be formed. It will forever stay as a fibrous tissue. But if there is a 10% strain, maybe it progresses towards us up to the stage of soft callus. But if there is less than 2% strain, then there will be formation of hard callus followed by the progressive mineralization. So a mature bone will be formed. So this is a picture showing the stage-wise healing of this indirect, like stage-wise secondary healing of a bone, where hematoma starts, first comes and fills the gap. And after that, there will be an inflammatory phase where the fibroblasts, all these cells will come and deposit over here and remain as a fibrous tissue. There is reduced movement. That is why all the bone fractures, everything is being stabilized at the initial stage. Either you stabilize the bone by putting a POP, like you stabilize the fracture by putting a POP, or you put a splint or a slab has been initially made. So that is why whenever a fracture case comes to any ear, orthopedician comes, before even orthopedician comes, some ortho technicians will stabilize the fracture because so that the fracture site is being pushed into this stage of healing. So a hematoma fills, then inflammatory phase, then a soft callus, and then comes this hard callus formation, after which a remodeling phase will be happening up. So this remodeling happens based on the force which passes through it. So though the excessive movement will not help in union of these fractures, but it also requires a slight stimulus to the fracture site. So slightest of the strain only will, or strain, it can also be taken as a stimulus. So slightest of the stimulus is must for any fracture to heal. Okay. So next is consolidation. So consolidation usually it's a process which follows the union of fractures and it indicates that the bone has returned to a normal strength. So this actually radiologically it can be demonstrated by the return of the normal corticular pattern of the bone. So this is the phase of the indirect healing of a bone. So next you must need to know certain terminologies in a fracture healing, which is union. So that is what we discussed right now. So here you can see a fracture line. So after all those interventions, a new callus will be formed and you can radiologically see there is a return of this cortical pattern of the bone, which indicates that that is a healed fracture. So it takes almost around 3 weeks. The next is same union. If it is not happening in an expected time frame, then it's called as, like it is a very slow way to heal, then it's called as a delayed union. And the other terminology is either non-union or malunion. So as it is shown in the image, non-union means the bones, the fracture site is not showing any potential to progress towards healing. So, or so this actually must be intervened. Unless intervention is being done, this will not heal or move to the next phase of healing. So, actually, you have to call this how long you can wait for bone or fracture site to be called as a non-union is that. See, when there is no evidence of healing that is progressing towards the healing for about 3 months, then it's called as a non-union. But you cannot apply this terminology non-union of fracture until otherwise, until it's been 6 months after injury. You should call a fracture site or a fracture a non-union only after 6 months from the injury. So what is non-union is that a fracture that has not healed or not showing any potential to heal for 3 months. So that time itself, you need to suspect that this fracture is moving towards a non-union. But you need to label this fracture as a non-union only after 6 months from the event or from the injury. So only then you can call this fracture as a non-union fracture. And the next is a malunion. So when the fracture segments are not properly aligned during the healing process, then it will malunite, or angulated malunion will be the ultimate result. So next, again, this non-union of this fracture can again be differentiated or classified as 3 types. One is atrophic, or the hypertrophic, or the third one is the infective type. So it's not uniting because of the presence of infection. So the cause for non-union, if it is an infection, so that is the third type. That's nothing much to explain about the third type. Whereas in atrophic and hypertrophic, as you see in the image, see, atrophic cause of the non-union has its own biological causes like lack of stimulus. As I already mentioned, for any fracture to heal, there must be some sort of or very slightest of the stimulus is needed for any bone to heal. So if that is not present, there is lack of stimulus or a lack of blood supply will lead to atrophic non-union. Whereas hypertrophic non-union, as you see in this image, there is overgrowth of the tissue. So which can even cause injury to the adjacent site or adjacent structures. So this happens when there is excessive movement to the fracture site. So that will result in a hypertrophic non-union. So again, now coming back to the substance, let's see what substance says. So here, radiographically, this acute and chronic fractures can be differentiated. So acute fracture, there will be a sharp, well-defined edges of these fragments, whereas in older fractures, all those sharp edges will be blunted, and there will be hypertrophy, and also there will be injury to the adjacent structure. So as it is shown in this image, this image A shows this acute fracture, which are the image which has been taken immediately after the injury. So you can see the sharp edges. Whereas in the image B, you can see there is some deposition, some callus formation, new bone deposition, mineralization, everything is happening here. And you cannot make out the sharp edges. It's been blunted. So image A is an acute one, and image B shows the chronic fracture. So radiologically, it can be differentiated. Now coming to some insight about the imaging in orthopedic surgery. So yes, it has actually CT, which enables the visualization of some fine details. So even finest details of the bony structures can be seen in the CT. But it doesn't mean that it is the first best investigation to do, isn't it? Fine details can be seen in CT. It even clarifies any abnormalities which X-ray picks. So again, Bailey states, radiographs are the best first-line test for any type of bone lesions or fractures. But it is CT which enables the visualization of fine details of bony structures. And also CT gives you the best three-dimensional information on the fractures. So in case of trauma, the initial imaging can either be a X-ray or CT. So whenever an option X-ray is given, you should always opt for X-ray. But the initial imaging can also be a CT. So to highlight that point, I have put this tabular column from Bailey. And if at all you're opting for X-ray, you need to ask for 2 views, either anterior posterior view, one is anterior posterior, the other is lateral views. But CT is already 3-dimensional, it gives you the 3-dimensional information. So there is no views with regards to CT. Again, Bailey states that you need to ask X-ray on 2 occasions. One is soon after the injury has happened, and the other is a second series of radiograph. That is whenever you doubt or you're dubious about that fracture is not healing. Maybe in 10 to 15 days, if you're suspicious that a bone injury is still persisting, then in that scenario or in that circumstance, again, you need to ask for the X-ray. So naturally, the answer here becomes the X-ray. So in a patient with non-healing fracture femur, next investigation is X-ray. Maybe after that, if X-ray is not given in the option, then you can opt for CT. An MRI is to look for the soft tissues and also the bone marrow. Any information is needed about the bone marrow, then at that time you can ask for an MRI. And to know the mineral status, so bone mineral, to know about the bone mineral density, you can ask for a bone scan. So this is how, so each option have a different questions to be framed. Got it? So for this question, what is the first next investigation? For the next investigation, in case of non-healing fracture femur, it's always X-ray. If you see X-ray, then it's always the answer. Next is a post-splenectomy patient. We have a post-splenectomy patient who had pulled out the Ryle's tube on second POD, and the patient presented with a severe abdomen pain. What is the likely cause for the symptom? Yes, so we have a post-splenectomy patient who pulled out the Ryle's tube on second POD, and after that the patient presented with a severe abdomen pain. Now, what will be the probable cause for the symptom? So I hope the question is clear. So the options are portal thrombosis, intestinal angina, acute MI, which is myocardial infarction, and acute gastric dilatation. So out of these four options, one option is very, it's quite easy to rule out. So it's obviously acute MI because there is no points favorable towards cardiac, isn't it? Like MI, it can occur if there is any cardiac risk factors being mentioned about the patient or any symptoms associated with it. Like though MI can present as an epigastric pain, so the abdomen pain, but it should be associated with some breathlessness, palpitation, but nothing like that is being mentioned. And also there is no risk factors specifically mentioned. So you can very well rule out or pick out this or remove this acute MI from this equation. Now the left out three options are there. That is portal thrombosis, intestinal angina, and acute gastric dilatation. So while performing a splenectomy, let's see how you're performing the splenectomy. So while performing it, to remove or you have to deal with this gastrosplenic ligament, which also have this short gastric vessels as the content. So this short gastric vessels, which supply the posterior aspect of the fundus and the cardia, it is a branch of the splenic artery. So you need to push the stomach towards the right side and then have to deal with this gastrosplenic ligament. So there is some kind of sort of meddling with the stomach, which leads to gastric atony. And that will lead to impaired gastric emptying. So if there is impaired gastric emptying, so there will be retrograde, right? So the antegrade peristalsis has been stopped. There is no movement in the stomach. So whatever the air or the fluid, whatever is being swallowed, sorry. So whatever air or fluid, whatever is being swallowed, it stays there. So there will be distension of the stomach causing pain. And also, so coming back, considering all these options, it's very easy to rule out these two options because these two options, option A, option B, that is portal thrombosis and intestinal angina, they both have a common underlying cause, which is the thrombus. They both are related to thrombus, like thrombus related event. There is one is having a portal thrombosis and intestinal angina, it's because of the thrombus in the mesenteric vessels. Got it? So both of them have a same underlying cause. And relating to thrombus, let's see what Sebastian have to say for us. So post-splenectomy thrombocytosis, it occurs particularly in patients with myeloproliferative disorders. That is, when you perform splenectomy for a patient with myeloproliferative disorders like CML or polycythemia vera or essential thrombocytosis, it is in that situation you need to anticipate a mesenteric or portal or renal vein thrombosis. And also, like whenever you think of answering any MCQ questions, always the common things should strike first, right? Either clinically or theoretically, common things always should strike first. And yes, here is what Sebastian says that the post-splenectomy thrombosis in the spleen or the splenic or the mesenteric or the portal veins, it has an incidence of only 8 to 10%, which is relatively very rare. And if at all if this thrombus have to happen, the risk factors are either if it is performed on a hypersplenic patient or if it is performed for a myeloproliferative disorders, which we discussed before. So there is no such risk factors such like this being mentioned in the question, and also it's very rare. So rare things should be pushed to the last option. So clinically or theoretically, the common things should occur to you initially. So now it has become so it's easy to rule out. So if at all, if you're not able to answer a question straightforward, it's very easy to answer the same question by ruling out the options. That is by removing the options from this equation. So again, reading this question, post-splenectomy patient pulled out the Ryle's tube, prematurely pulled out Ryle's tube on the second pre-OD, and the patient presented with severe abdomen pain. Now, the likely cause, you have the Ryle's tube pulled out, so there has been a, already we discussed that there is a gastric atony causing impaired gastric emptying, so there will be, obviously there will be distension of the stomach. But with this Ryle's tube being pulled, the only option to decompress the stomach is also been removed. So obviously the answer becomes the acute gastric dilatation, which would have been the, which is the probably the cause for this severe abdomen pain. I hope the options and explanations are clear. So, and moreover, this portal thrombosis is more common when you perform a lap splenectomy, and it presents with fever and ascites. There will be distension rather than pain. And this intestinal angina, it's more common after, the pain will be more common after taking meals. That is postprandial pain will be the highlighting symptom in this, in such patients. And acute MI, it's already been ruled out before even we got into the discussion, we ruled out that acute MI. And keeping the clues and glitches that's been present in this question, with Ryle's tube pulled out prematurely on the second POD. Soon after that, the patient had a severe abdomen pain. Directly and naturally, the answer becomes the acute gastric dilatation, but still you need to know the explanation. So portal thrombosis is more common when you perform splenectomy on myeloproliferative disorders like CML or polycythemia vera. Got it? Now let's see the other complications after splenectomy. Like it is pneumonia. It can be pneumonia because of the meddling in the left side of the diaphragm. It can also cause pneumonia and left-sided pleural effusion, which is a reactive effusion. And retaining a drain tube for a prolonged days can lead to subphrenic abscess. That's why it's probably like normally it's not advised to keep a drain after splenectomy, because there are more chance that it might lead to subphrenic abscess. And pancreatic fistula. So when you're dealing with or meddling with the splenic hilum, which also contains a pancreatic tail as a content, inadvertent injury of the pancreas might lead to this pancreatic fistula. And gastric perforation, again, while meddling with this gastrosplenic ligament and the short gastric vessels, if it's been cut off, then there are a lot of chances that there can be an ischemia leading to gangrene, followed by a perforation of the stomach. So this again becomes an emergency, so the patient have to be taken for the laparotomy to address this issue. So moving on to the next question. A CT abdomen of a patient who sustained gunshot injury showed through and through perforation to sigmoid colon without any history of patient's vitals. So what is the most appropriate treatment? So a CT of the patient shows through and through perforation of sigmoid colon. So you have a patient with through and through perforation of sigmoid colon, but no information about the patient's vitals. Now, what will be the most appropriate treatment? Now, let's move into the options. Whether you have to perform a resection anastomosis or keep the patient under observation, or a colostomy is performed, or a damage control surgery is done. So the question looks slightly tricky with all those no history mentioning the patient's vital. But when you consider the options, it becomes easy. So definitely for a through and through perforation of a sigmoid colon, we will not keep this patient under observation. So that has been ruled out. So one option is being taken out of this equation. Now we have the other three options. So before that, any colonic injuries from a penetrating trauma, it should be managed based on following considerations. That is, you need to consider the patient's hemodynamic stability, but about which we don't have any information. So we can take it like this. Maybe it's not worth mentioning. So it can be safely considered as the patient is stable, hemodynamically stable. So if there is no information or specific mentioning done about the vitals, it can be safely regarded as the patient's vitals are stable. So one thing we have clarified. Next is degree of contamination. Again, it's not mentioned. And because the patient is considered as stable, maybe the contamination is not very heavy, because heavy contamination will lead to sepsis and peritonitis and septic shock. Again, the condition or the hemodynamic stability will be in doubt. So again, there's no stability doubt in hemodynamic stability. So this is again maybe taken in a safer view. So next, regarding the extent of tissue damage. So now we have to focus only on this extent of tissue damage because that's been given in the CT. That is, we have a through and through perforation in the sigmoid colon. So with this information only in hand, what will be the next appropriate management? So that is the question. So now basically we thought we are considering that the patient is stable. So when the patient is stable, you need to think of the management only keeping in mind that the extent of tissue damage. So for a through and through perforation, you can't keep repairing it, right? So maybe the best option to go with is resection and anastomosis. But before going into a total care, whether you need to take the patient for the early total care or a damage control surgery, you have two options, either damage control surgery or a early total care. You need to plan, like the decision on this is being made on the basis of the venous lactate levels. So a tabular column in a Bailey states that it is an essential marker for resuscitation. So naturally, when a patient is hemodynamically stable, obviously the serum lactate levels will not be very high. So it will be obviously less than 2. So when the lactate levels are less than 2, you need to plan for an early total care. So because we consider this patient's hemodynamic status as stable, it's quite stable and not contaminated. So we have to plan early total care for this patient. So that is why, again, going through this question. So CT of a patient shows through and through perforation to sigmoid colon without any history of patient's vitals. Now, what will be the most appropriate treatment? You go with resection anastomosis or observation or colostomy or damage control surgery. So again, observation was being ruled out already. So again, if you still have doubt, you can consider the C or D. See, even in damage control surgery, what will you be doing? You have to keep a colostomy and come back. So more or less, these two options are same. So the options are very easy to rule out here. So if at all you're not, you find that the question is tricky, try to answer with the help of the options by ruling out the options. So then naturally our answer here becomes resection and anastomosis because it is safer to because it's not worth mentioning. That's why the vitals are not mentioned here. So the examiners or the one who framed this question has trickily inserted all these points like without any history on patient's vitals. So considering only the extent of tissue, you need to go for the resection and anastomosis. So the colonic injury have to manage based on the dynamic hemodynamic stability or the degree of contamination and the extent of injury. Now we have in our hand, we have only extent of injury information. So keeping that only in mind, you need to go for the resection and anastomosis. That becomes the best answer for here, for this question. Next, this is a very simple and straightforward question. So for a carpal tunnel syndrome or for any injury that causes a nerve compression, a pressure relieving procedure was done under local anesthesia. Now, what could be the drug whose effect will last for about 8 hours? So among the given options, which drug is long acting is the straightforward question. So lignocaine, bupivacaine or mepivacaine or procaine. So here in Sabiston, you have a direct tabular column which states that you can see here over here, lignocaine and mepivacaine duration of action is just 1 to 3 hours, whereas bupivacaine and ropivacaine, you have 3 to 6 hours. The action is up to 3 to 6 hours. This is 180 to 360 minutes, right? So it's about 3 to 6 hours. So it's a very direct question. The question is asking about 8 hours. Lignocaine and mepivacaine is having only 1 to 3 hours duration of action, whereas bupivacaine it's about 3 to 6 hours. Procaine is another short-acting local anesthetic agent, and moreover, the liposomal suspension of this bupivacaine can even act up to 72 hours. So the answer here becomes the bupivacaine. Moving on to the next question. So here the patient presents with a chest injury with a sucking wound. There is a wound, open wound in the chest. Now, what will be the best next step in this situation? Either you need to put an ICD, so there is an open injury with sucking wounds. The air has been sucked inside. Probably it is leading to pneumothorax. There is an airway compromise over here because of the compression, right? So what will be the best next step here? You need to put an ICD or you need to intubate the patient or a 3-way flap closure is done or a definitive surgical repair is done. So I already explained the situation. The patient is having an open injury in the chest with sucking wound. So through the sucking wound, that is open injury, the air has been entering inside that might cause pneumothorax. So whenever there is an opening in the chest wound, which is more than 2/3 of the tracheal diameter, then the air will preferentially enter through this wound. It will not enter via the trachea. So whenever the open wound's diameter is more than 2/3 of the diameter of the trachea, then the air preferentially enters through that wound and cause open pneumothorax. Now, what will you feel is that immediately you need to put an ICD, but that is where you make a mistake. So initially, the initial management should be, you need to stop the air which enters inside. First, stop the air which enters inside. For that, you need to apply a three-way closure, like three-way flap closure is the initial thing you need to do. So the Bailey states that the initial management consists of promptly closing the defect with occlusive, like sterile occlusive plastic dressing that is to be taped on three sides so that it acts as a flutter type valve. That is, air can come out, but it cannot enter inside. So the initial step is that the promptly you need to close that open injury wound. The open wound have to be closed. So that is the initial management. Following that only, you need to insert a chest tube as soon as possible. Maybe not in the same site. It should be done in a remote, like in a different site. Not the same opening you should put. You need to put insert an ICD in another wound or another site. Not in the same wound. Got it? So this is the three-way flap closure where it's been taped on three sides and the fourth side has been left open so the air comes out through that. So it acts as a flutter type valve. So again, going through the question, a patient presents with chest injury and a sucking wound. What is the best next step? ICD, you all will be attracted towards this option A. Most of the time, option A will be wrong. So don't fall into the trap. So tube thoracostomy is the second step. Only after closing the open wound in the chest, you need to go for a tube thoracostomy. And endotracheal intubation, that also can be done, but if there is a severe respiratory distress. So if there is a severe respiratory distress, then opt for endotracheal intubation. But the initial best step will be the three-way flap closure. And when will you go for this definitive surgical repair is that when there is a large defect or a persistent opening or persistent defect, either large or persistent defect, you need to go for a definitive surgical repair. So here, the first step is to close the wound, close the opening through which the air enters so that the entry of the air is being blocked. And after that, so this is the order. And after that, ICD is being inserted at a remote site. And then if there is a severe respiratory distress, intubate the patient. And again, if there is a persistent or if there is a large wound, then you need to focus your attention towards the wound, for which you need a definitive surgical repair. So that explains all this. So yeah, here the answer is three-way flap closure. The next is in a patient with tension pneumothorax, what is the needle thoracostomy site according to ATLS? So according to Advanced Trauma Life Support, a patient with tension pneumothorax, where will you insert the needle is the question. So you don't jump into the options soon after you read the question. So the question is very crisp and clear. No, it's not ending here. So tension pneumothorax, site of the thoracostomy site, fifth intercostal space. No, it's never like that. I already told you option A will be very attractive to you. It appears attractive, but never. See, the question is very crisp and clear. It is asking the needle thoracostomy site according to ATLS. So according to this 8th edition of ATLS, if at all you're planning for a needle thoracocentesis, then the site is second intercostal space in the mid-clavicular line on the side of tension. But it also has some risk, like if at all, if there is no, like if you have diagnosed the patient wrongly, the patient is, if at all a patient is not having a tension pneumothorax, then upon inserting the needle, you might damage the lung. So you need to be very careful. But if you're planning for putting a chest tube or ICD, in that case, the site will be the fifth intercostal space just anterior to the mid-axillary line on the affected site. So you need to know this. According to 8th edition of the ATLS, it states when it is a needle thoracostomy, it is the second intercostal space. And with regards to ICD, it is the fifth intercostal space. Again, Bailey says it's been historically taught that insertion of a large bore cannula, which is needle, it's in the second intercostal space in mid-clavicular line. Whereas ICD, it's in the fifth intercostal space in the anterior axillary line. But if the same question, what if the question is framed in such a way that it's asking what is the current teaching, something like that? What is the advanced or what is the current teaching of this or current like protocol to do to manage this tension pneumothorax? And if at all there is an option like safety triangle option, in such case you can opt for this safety triangle because where the boundaries are The posteriorly it's formed by the latissimus dorsi, anteriorly by the pectoralis major, and inferiorly it's formed by the line which runs from the nipple backwards, reaching the latissimus dorsi. So in this safety triangle, you need to do a finger thoracostomy. So this is the current teaching. But if at all it's asking for any latest or advanced protocol without mentioning ATLS, then in that condition or in given that state, you can opt for a safety triangle option. So here, according to ATLS, tension pneumothorax, where will you insert the needle? It's the question is very precise, crisp and precise. So you need to choose the second intercostal space in the mid-clavicular line as an option. Got it? Yes, then the final question of this module is you have an RTA patient with pneumothorax and the patient was received in the ER. So there was an ICD placed in the fifth intercostal space, after which a huge gush of air was released. So every line in the question is a clue for you to answer. So kindly read all the word, read the question word by word. So you received a patient with a pneumothorax in ER. ICD was placed in the fifth intercostal space. So after which there was a leak, like a huge gush of air was released or leaked. And upon examination, there was a subcutaneous emphysema that was present all over the chest, upper chest, shoulders. Now, what will be the next best option? So you need to continue observation because subcutaneous emphysema will resolve on its own, or you need to attempt to rule out any injury to trachea or bronchus or esophagus, or you'll put a multiple skin incision to relieve emphysema, or video assisted thoracoscopy should be done on emergency basis. So quite like a lot of theory is given, right? But it's very simple. Simple, that you have a pneumothorax, a patient with pneumothorax, ICD has been already inserted with a huge gush of air is being coming out and emphysema is present. What will be the next option? Yes. So moving on to the discussion. See, if there is a huge gush of air, even if, like upon inserting ICD, it means that there is a bronchopleural fistula. So upon inserting an ICD, there is a huge gush of air that's been coming out. It suggests that there is a presence of like some massive airway injury is present. There is a bronchopleural fistula. And also, if there is a persistent subcutaneous emphysema despite a functioning ICD. So ICD has been already inserted, but still there is a subcutaneous emphysema which is present all over the upper chest and neck and shoulder. That was what is mentioned in the question, right? So if there is a persistent subcutaneous emphysema even after inserting an ICD, so again, the same massive airway injury is the concern. Maybe it could be an airway injury or even esophageal injuries because you even swallow air, right? So even esophageal injuries also will present with the same finding, especially in addition to this, there will be pneumomediastinum. So what you have to do, yes, Bailey states here, see the severe emphysema, subcutaneous emphysema with respiratory compromise, which is pneumothorax. It suggests tracheobronchial disruption. So as I already told you, so there was a huge gush of air upon ICD insertion, so which means that there is a bronchial pleural fistula. That is a tracheobronchial disruption or a massive airway injury. So there was a severe subcutaneous emphysema with pneumothorax, that is with respiratory compromise. So you need to suspect a tracheobronchial disruption. So the next immediate step is to place or insert a ICD. Chest drain have to be placed. But that also, that if the question is not mentioning about ICD status, then what is the next best option? You need to insert an ICD because saving or maintaining the airway patency is comes first in the ATLS protocol, right? ABCD. So you need to maintain the airway for which you need to put an ICD. But the patient had already been inserted. That is what is being mentioned. Already ICD have been inserted, upon which it reveals a large air leak. Again, it points towards the same concern, that is that there is a massive airway injury, which is tracheobronchial injury. Now, what happens is that to the side of the lung where the trachea or bronchus has been injured, that side of the lung will not expand. It's been collapsed because of the air leak. So now you have to move towards the diagnosing and confirming the diagnosis, for which bronchoscopy is diagnostic. And next comes the treatment, which is intubating the opposite side. That is, unaffected bronchus have to be intubated and ventilated because that takes care of the perfusion. So circulation also have to be taken care hand in hand. Following which you need to go for an operative repair. You need to stabilize step by step. So airway have to be maintained, like patency have to be maintained. So inserted ICD and then do some evaluation. So do a bronchoscopy. Like upon placing ICD itself, there was a massive air leak, so suggesting a airway injury. To do a bronchoscopy or endoscopy to rule out a esophagus injury, and then intubate and take care of the circulation, like intubate the unaffected bronchus, and if at all possible, go for operative repair. Otherwise, refer the patient to the trauma care. So this is the order. Why not this option, multiple skin incision? Yes, it may help to decompress the subcutaneous emphysema, but it does not address the underlying cause. It is only a symptomatic management. So what is the point in giving you clues like there was a huge air leak, blah, blah, all such things. So when your eyes don't see, your mind doesn't, when your mind doesn't know, your eyes don't see. There's a saying like when a mind doesn't know, your eyes don't see. So when there was an ICD insertion, there was a huge air leak. So what's the point in giving all those key points? So you need to address the cause, not a symptomatic management. Simply putting a skin incision is just addressing it symptomatically. And next is doing an emergency video assisted thoracoscopy. It's not the next immediate step up. So next immediate step is you need to do a bronchoscopy and endoscopy to rule out massive airway injury. Maybe VATS may be later on needed. Maybe it's needed later on. And in case of massive emphysema, you can't sit and simply observe without ruling out this massive airway. It will only further cause delay, isn't it? Again, coming to the question, so RTA patient with pneumothorax, ICD was placed, ICD was placed in 5th intercostal space, and was released. So there was some, even after ICD insertion, emphysema present over upper chest and shoulder. So now, even after all this explanation, I hope you all got clear with my explanation. So next best option is never continue observation. See, it's a common mistake or misconception that subcutaneous emphysema will resolve on its own. That's why option A, continue observation, is being given. Again, it's a falsely attracting option. So next is an attempt to rule out injury to trachea, bronchus, esophagus. So we have discussed that to do a bronchoscopy is diagnostic or endoscopy is diagnostic to rule out massive airway. So option B naturally becomes an answer. And why not multiple scale incision? It will only address the problem symptomatically. And that's, it's not done on emergency. Like it is, maybe it's not the next best. Maybe later on it's needed. So naturally the answer here becomes the attempt to rule out injury to tracheobronchial and esophagus injury. So that's it. So thank you guys. Prepare well, all the best.